So with that, I want to hand things over to Fred to take us through our first case study of a patient dealing with non-sustained VT below the rate cutoff of your therapy zones or even in your monitor zones. What do we do with that information?
Thanks, Kate. Yeah, we're going to talk a little bit briefly about non-sustained VTs or VTs, slow VTs, maybe you might call them, but really slow is probably relevant to what the zones are, right? So when you start seeing some NSVTs, and if you guys are seeing patients, you're probably seeing some NSVT every day, 3 seconds, 5 seconds, 7 seconds. What is significant? And you have to kind of put it in a bigger picture of does this patient routinely do this? They have a pacemaker and they do 3 or 4 beats every quarter or a couple of times a week or whatever. If that's kind of like their thing, you kind of learn. But when it becomes a little bit longer, where it might start becoming more clinically significant, where is that, right? And when you're working with your people, you kind of know what the cutoff is, what they like to tolerate, what that guideline is. But understanding that every patient is different, right? They're different based on their EF, their blood pressure, et cetera. So you start getting newer onset, longer, non-sustained VT in the quote monitor zone or under the monitor zone. You've got to start asking yourself, what else is going on? Is this new? What else is, the patient have a recent MI, things like that. To figure out, do you escalate this? Do you start making it? For the most part, it's not. It's benign. A lot of us kind of have a little bit of something once in a while, maybe in traffic or et cetera, maybe a beat or two, but you have to watch it. The other thing is that maybe it's a primary prevention patient and they have a high zone and they're set at 200, single zone. And all of a sudden they start having, some VT at 180. It's in the monitor zone. It's grabbing it. It's putting it out there for you. It might be relatively sustained. Is that actionable or not? It might be. What we do know is that most of these VFs that patients have usually start in form of some high fast VT or and accelerate and get worse a large part of the time. So when you start seeing that at a higher rate, longer, obviously is when you might want to start, elevating this. Some of your sickest patients on the completely end of the spectrum can have these incredibly slow VTs. So just as you see a VT that's relatively slow, in the presence of a lot of other things going on, some of your sickest patients can have slow VTs that are kind of sometimes hard to treat and hard to set up therapies for, and they don't tolerate. So don't just look at VTs or slow VTs or rates that are slow and insignificant as if they're having them once in a while. If it's in the presence of a BIV, right? If they're doing a lot of this, having lots of extra beats, they're knocking down your BIV pacing. Yes, some devices, the devices do have some type of, response pacing that may or may not be nearly as good. But understand that, may not, be as effective. So it may cut into your BIV. When you're looking at devices and you're looking at, depending on what device you're looking at, sometimes they qualify them as VT in the monitor zone, sometimes they're ventricular sense episodes, et cetera. And this is, in this case study here, it shows marker channels, doesn't give you the EGMs, but you get marker channels. And you can see in the bottom where you're having some VT, some slower VT. It's trying to, looks like it's doing some pacing over the top of some of it a little bit. But you're having these runs and runs and runs. And when you start doing that, you want to take a look at what they're doing. How much of this are they doing? In this particular device, the Medtronic device, on this next slide, that kind of shows you have a log that will accumulate this data and take a look to see how persistent is it? How much is it biting into your BIV pacing? How long are your events becoming? What's the average run on them? So don't just cast off non-sustained slow beats, in particular if you have a single zone, because that's when you may need to, may want to start adding another zone as well. So that's pretty much what I have for that, Kate. I'll turn it back to
Great.
you.
Yeah, Keith, did you have anything to add?
No, I think it's a it's a great point that Fred makes as far as like the context with the patients here. And I think there's been definitely a change since I started in this field a few years ago, as far as how we approach VT. And, when I started, a few beats of VT were concerning on a device. We wanted to make sure we caught all of it. And Kate, I think as you're going to mention here soon, we've learned a
Mhm.
lot about how patients tolerate VT and the different ways we can approach it now.
Yeah, yeah, definitely. So, I think just going back to this ventricular sensed episode, I think a lot of us probably would look at this and the purpose of having these ventricular sensed episodes from Medtronic devices is to help us figure out why are we not biventricular pacing, but it's also a great place to catch slow VT below the monitor zone. So, as Fred talked about, it's here's a VT. We can all agree it's VT. It's the ventricular rate is greater than the atrial rate. A lot of us probably would be alarmed by this, and I think this has changed over the years. But like, oh no, they're having VT that's falling below the monitor zone. This is a really big situation, an emergent situation. But when you look at it and really think about it, okay, the duration is 6 seconds, 8 seconds, pretty short. It's non-sustained. It's slow. Maybe check in with the patient, make sure they're feeling okay. But that's not something we want to treat. And as Keith said, this has changed over the years. And a big reason for why our kind of approach to managing these arrhythmias has changed is because of the different clinical trials that have taken place. So I want to talk briefly about the MADIT-RIT trial. So this was a study that was looking to see how we can reprogram devices with the goal of reducing inappropriate therapy in patients with ICDs. So they broke off their patient population into three different branches. One was with kind of standard basic programming. Arm B was the high rate cutoff arm. And that looked at, how do patients fare if we increase the rate cutoff of our therapy zones? And then arm C looked at, okay, how do patients fare if we extend the detection delay or the duration delay in these patients? The number of intervals needed to meet detection instead of it being, a 2.5 second delay, or maybe looking at 12 fast beats. What happens if we extend that to 30 or more beats needed before we deliver therapy? So this was a really pivotal trial because of the results. So based on the results, they were really, really interesting and exciting and new results that, as we've alluded to, it's kind of changed the way we program devices because it was found that these patients had a reduction in first um, occurrence of inappropriate therapy. So they were having fewer inappropriate shocks. They had a reduction in all-cause mortality. And there was no difference in adverse events. And there was actually an increase in quality of life. So patients were doing better. And they were getting they were getting fewer inappropriate shocks, which I'm sure everyone feels good about. So we had all these really good outcomes with no significant difference in bad outcomes for the patients. So again, this really drove how we then program devices, right? So devices a lot of times these days are programmed with a high rate cutoff with a delayed detection criteria to try to promote the reduction in mortality and also promote the reduction in inappropriate therapy. So this really reduced those non-sustained episodes or maybe the episode or getting therapy for episodes that were hemodynamically tolerable. So it drove programming so much that the Heart Rhythm Society actually came out with a consensus statement on how they recommended devices to be programmed. And actually, in 2019, there was an update to provide specific information on different manufacturer programming guidelines. So we're just going to talk kind of generally, but that 2019 update is really important. So generally, they recommend that we increase the rate cutoffs for our zones in our therapy zones and also increase the detection criteria. So again, specifically, what does that look like? For primary prevention patients, they recommend that we increase the detection criteria. If it's Boston Scientific, we've programmed number of seconds, 6 to 12, or if all the other companies, you program a number of intervals, programming your detection criteria all the way out to 30 intervals before detection is met, before we can move on to therapy. Also, from a zone standpoint, again, for primary prevention patients, they recommend that the slowest therapy zone should be no slower than 185, right? It should be somewhere between 185 and 200. So we don't want to have our primary prevention patients having slow zone cutoffs below 185, right? Studies have shown that having those higher rate cutoffs lead to better outcomes for patients. But, as we talked about, that might mean that some patients do have VTs that are less than 185 that are falling outside of your therapy zone. But again, studies have shown that patients can tolerate those pretty well and they do self-terminate. So they're not always an emergent situation if we're having VT below the cutoff zone. For secondary prevention patients, very similar guidance, similar guidance on the detection duration criteria. And then your zone cutoffs, we want to make sure that we have discrimination algorithms to help differentiate VT from SVT, and should be used even in faster rates, right? Rates up to and including 200, potentially up to 230 to reduce inappropriate therapies. So really important, this uh, consensus statement really provided some solid guidance for all of the different manufacturers as to what we should be programming to help our patients as best we can.
Kate, if I could just add to that before
Yes,
you move on to the
please.
next case study, I do want to again put in a plug, as you said, for that 2019 focused update, because it gives good recommendations by each manufacturer. And I know each manufacturer is different and unique, and kind of walks through those. And I think, but it also emphasizes, as something I think you alluded to earlier, is that, every patient's unique and different. And, they don't want people to look at these as blanket recommendations, but guidelines to help you, with inside of your programming for these folks. And, as we talk about these slower VTs, I think a really important thing that you mentioned earlier is, talking to that patient. Let's understand what's going on. And the key things with regards to classifying these arrhythmias is about, how hemodynamically stable is that patient, and what's going on. But we do, and we found that, that patients can be, hemodynamically stable with slower VTs, but keeping that patient always in the center of what we're doing and talking to them and looking at them, particularly in the world of remote monitoring. And I know that that's something that our teams focus on, making sure that they're talking to the clinics that they're working with, and making sure that they know when to reach out to patients, et cetera. So, but excited to see the next case study.